They're unmuted. Thank you all for joining us today for today's version of, or today's edition of What's New in Addiction Medicine. My name is Paxton Bach. I am the program director for our fellowship program, and delighted to introduce our speaker today. Dr. Grace Zhu is a family medicine trained physician. She did her med school and residency training at the University of Ottawa, where she developed an interest in addiction medicine and patient-centered care, which led her to come here to our addiction medicine fellowship. She's speaking to us today about a topic that I think is so incredibly topical and relevant, that comes up every single day of my clinical life, and that I think many of us feel pretty ill-equipped to have really informed conversations around. So I think this is an excellent topic for today, and I look forward to trying to learn something myself. She's going to talk to us, give us a talk called Under New Management, Insomnia, Pharmacotherapy, and People with Substance Use Disorders. We'll ask you to hold your questions to the end, and there'll be plenty of time for Q&A afterwards.
All right. Hi, everyone. My name is Grace. And so let's get started because we have a lot to get through today. Before we get started, I want to take a moment for a territorial acknowledgement. I respectfully acknowledge that I am a humble guest on the unceded and stolen homelands of the Musqueam, Squamish, and Tsleil-Waututh nations. No conflicts of interest to declare. And in terms of what we're going to talk about in this hour, we're going to do a little bit of background information, talk about the relationship between sleep and substance use, then take a dive into the literature available in terms of certain sleep medications that may be commonly seen in substance use disorders, and then figure out how to apply that to our practice. All right, so before we jump into that, we're going to talk a little bit about the neurobiology of sleep. So this is a very simplified version of what it probably looks like in our brain, and I probably can't describe it any more in depth than this. But the first thing to note is this guy in purple, VLPO. It stands for ventral lateral preoptic nucleus. It's part of the hypothalamus, and it essentially is the guy that promotes sleep. It produces what I call the sleepy neurotransmitter, so GABA, and that's how we feel a little sleepy. In the wake state, we have the guy in blue, monoaminergic neurons. They're basically just a type of neuron that produce norepinephrine, acetylcholine, and serotonin. That's kind of located in all sorts of areas in the brain. And that's kind of what promotes the wake state. Orexin and histamine are also players that kind of contribute and kind of help promote the wake state too. I mention all these names and terms because a lot of the medications that we look at kind of play a role in kind of either inhibiting the wake state or promoting the sleep state. And that's why I wanted to give you guys a little bit of background. And then in the sleep state, the VLPO also kind of inhibits the wake state stuff. All right, we're also going to talk a little bit about the circadian rhythm, but I'll do that a little later. So a little bit about substance use and sleep. The literature found that essentially there's a bidirectional relationship between the two. So essentially one contributes to the other and vice versa. And a prospective longitudinal study actually found that individuals who had insomnia were about 7.2 times more likely to report substance dependence about 3.5 years later. And then on the flip side, chronic substance use has been associated with poor sleep, specifically increase in sleep latency, reductions in total sleep time, and reductions in slow wave and REM sleep. And in terms of how prevalent it is in our population, it's varied. They're more likely to have concurrent sleep disturbances. And one interesting fact, over 75% of persons on methadone maintenance therapy often will report sleep complaints, which probably isn't super surprising for the people who kind of see this population. In terms of the impacts of poor sleep in substance use disorders, it's commonly linked to low mood, increased stress, and greater pain sensitivity. It's also been identified as risk factors for kind of increasing risk of relapse. Namely, they identified decreased REM latency and slow wave sleep, so the quality of sleep. And it could potentially be a trigger for relapse in abstinence. And a study looked at a group of patients with alcohol use disorder who had insomnia symptoms and compared them to those without, and found that they were essentially twice as likely to relapse from the group that they looked at. So all this information illustrates the importance for us to understand how to better manage insomnia symptoms in people with substance use disorders. All right, so a quick overview about the current insomnia guidelines. There's kind of a lot kind of spread out everywhere, but I tried to pull from something more BC Canadian focused. It's pretty similar to the American Academy of Sleep Medicine as well. So this is from the BC Provincial Academic Detailing Service, and these are essentially the medications that are currently approved by Health Canada for insomnia. So this includes benzodiazepines, Z drugs, doxepin, which is a tricyclic antidepressant, as well as orexin receptor antagonist. So that would include lemborexin, suvorexin, things like that. The challenge with kind of these medications, especially in our context, is one, the guidelines that kind of recommend these medications and are based off of studies that often will exclude people who use substances. So it's hard to know if it really applies to our population. The other thing is several of these medications are associated with risk of dependence, misuse, addiction, and there may be safety concerns as well for some of them in terms of mixing with other narcotics. The other thing is there's often not a lot of studies done in substance use disorders. When I actually took a look, for instance, I couldn't find any for doxepin, even though I tried really hard. Diving a little bit more into the benzo and Z drugs. So again, these were some of the recommended medications by the insomnia guidelines, but with kind of the known risk for misuse, dependence, overdose, as well as CNS depression. So generally, a lot of the literature that looks at insomnia medications in our population suggests that they should be generally considered as contraindicated. All right. So what would be kind of the perfect medication that we would look for our population? One, we want it to actually work in terms of our insomnia symptoms, be relatively safe, so low adverse effects in terms of misuse and kind of respiratory depression, and hopefully it at least helps with our kind of substance use outcomes, such as risk of relapse and things like that, or at least has no impact on them. So with that in mind, I picked 6 medications that essentially I found were very prevalent in kind of the practice I've been seeing. As you'll notice, a lot of these are off-label medications for sleep, but they're still they're often prescribed, so I thought it would be relevant to take a look at. The other thing to mention is that a lot of the studies I looked at kind of talk about criteria is based off of like DSM-4. So sometimes I'll say things like cocaine dependence, things like that. And it's just because of the literature and kind of the language they were using at the time. Okay, so we have a lot to get through. So the first guy is trazodone. So trazodone is a serotonin antagonist and reuptake inhibitor. And it's often prescribed off-label for sleep, but it's actually, interestingly enough, not suggested to be used for insomnia by the American Academy of Sleep Medicine. And that's really based off of the fact that, based off of the moderate quality evidence that they saw, they didn't find any any clinically significant data to support it. But they do note that a lot of people will use it. And actually, in a national survey of addiction specialists in the 2000s in the States, it was cited as the most frequently prescribed medication for sleep for alcohol use disorder. So what's the evidence in substance use? There were several studies that noted benefits for sleep disturbance in alcohol use disorder, named both kind of subjectively with kind of insomnia scales and indexes, as well as objectively with polysomnography. And for opioid use disorder, I honestly only found one article that looked at, it was an RCT that looked at methadone maintenance therapy and found that it wasn't really clinically significant. The one thing that I want to bring your guys' attention to is a article by Freeman Group from 2008. This was one of the randomized control trials that looked at trazodone in alcohol use disorder. And while they did find benefits for sleep, they did notice some potential adverse effects in kind of our substance use outcomes. They found that when they were giving trazodone to the cohort, there was less improvement in the proportion of abstinent days. And also when they had stopped the trazodone, they found that there was an increase in number of drinks per drinking day, about an average of 4.6. And the study authors were quite surprised by this, but they thought maybe this was because trazodone can be viewed as structurally similar to alcohol. And so maybe the abrupt cessation of trazodone may have led to increased cravings from that, and thus why there was increased drinking days or drinks per drinking day. One thing to note about this study is that they excluded participants who were on other forms of antidepressant medications as well as any anti-craving medications. So it's unclear if they were on like a guideline recommended treatment such as naltrexone or acamprosate, if they would still have these sort of outcomes. I want to quickly jump ship to talk about the Canadian Alcohol Use Disorder Guidelines from 2023, and namely recommendation number 12, that's highlighted in blue, which basically outlines adult and youth patients should not be prescribed SSRI antidepressants for the treatment of AUD. And in the body paragraph, they actually cite that article that we just talked about, the trazodone paper, kind of to support their point, really just illustrating how much weight that paper was held in their eyes. So I also want to take a look at trazodone in a population with alcohol use disorder, but also with comorbid major depressive disorder. This was a retrospective study in Italy that did that. They did prescribe trazodone at kind of the more antidepressant ranges as opposed to the sleep ranges. But they did notice improvements in sleep as well as cravings from this. So there may be potentially a role for trazodone in alcohol users with comorbid depression. All right, so number 2, we have gabapentin. Gabapentin is a medication that indirectly modulates GABA, which, as you guys remember, is the sleepy neurotransmitter. In primary insomnia, it's known to improve slow wave sleep, increase sleep efficiency, and decrease spontaneous, arousal. In general, we use gabapentin often for mild alcohol withdrawal management, but it's also often used off-label for insomnia. We have a nice systematic review and meta-analysis published in 2020 that took a look at gabapentinoids for the treatment of alcohol use disorder, and they looked at various effects such as withdrawal, craving, depression, and sleep disturbance. So this table is pulled from that article. It just summarizes the meta-analysis results of kind of those effects that we talked about. And I want to highlight kind of the guy in blue in the middle. Basically, they found gabapentinoids had no effect on cravings and sleep disturbance. You'll note that if you kind of in the far right, the heterogeneity of the articles that they looked at for sleep was really, really high. It was 97.4%. And so the effect size they needed was a lot higher. And they unfortunately just couldn't meet that threshold. The study authors also mentioned that there were other systematic reviews that did illustrate some benefit for gabapentin in alcohol use disorder for sleep, but it was primarily in groups that had restless leg syndrome and fibromyalgia, which can be kind of treated with gabapentin. In terms of other studies, there was a study that looked at gabapentin and naltrexone in combination in a randomized controlled trial, and they found that this combination significantly improves sleep compared to both the placebo and the naltrexone group. And there was another recent RCT from last year that essentially found gabapentin was helpful for sleep, but they found that having baseline sleep problems kind of better predicted greater success for reducing drinking in gabapentin treatment, just illustrating kind of the importance of sleep management as well. And we talked a lot about alcohol for gabapentin, mainly because a lot of the literature is on that. I tried to find other substance use disorders. Unfortunately, I can only find one that also included alcohol use disorder, but with comorbid opioid use disorder, and they basically didn't find much benefit. The in terms of gabapentin, I did want to highlight some potential safety concerns as well. There isn't a known increased risk for opioid-related overdose with co-gabapentinoid use. Interestingly enough, they found that with clinical lab studies that gabapentin didn't necessarily enhance alcohol's depressant effects, suggesting it may be a little safer in alcohol use. There's also documented literature of misuse, as well as opioid use disorder identified as the most common substance use disorder that's associated with misuse. So with all that in mind, there may be a potential role for gabapentin for sleep in alcohol use disorder, but with the other substance use disorders, we really just don't have that much information. And there is this kind of known safety concern, especially with an opioid use disorder. So I think a lot of caution should be taken. All right, so number 3, we have quetiapine. Quetiapine is a atypical second-generation antipsychotic, and it's known to have some sedating effects, and it's thought that it's probably because of its antihistamine effects, as well as it has some antagonistic effects at the orexinergic receptors. In the general population, it is known to improve sleep quality as well as increase total sleep time. But despite these known benefits, it's not recommended as treatment for primary insomnia by choosing wisely. And this is due to essentially the significant side effects it can create even at these low doses that we prescribe for insomnia. So that would be the extrapyramidal symptoms as well as the metabolic side effects. Additionally, it can be used for non-medical purposes as well. Oh. So looking at the literature available in substance use, we have a literature review that looked at quetiapine for AUD management, and they found that there was utility for quetiapine as an adjunctive alcohol use disorder pharmacotherapy in terms of its kind of abilities to reduce cravings, sleep, as well. Reduce cravings, improve sleep, and reduce anxiety. They found in particular that it was most beneficial for individuals who had comorbid psychiatric conditions, such as mood, anxiety, or primary psychotic disorders, as well as what they call type B alcohol-dependent individuals, which is a group classified as kind of earlier onset alcohol use disorder with childhood risk factors, family history, and often other substance use disorders too. Of note, from this literature review, a lot of the studies that they looked at did look at quetiapine at much higher doses than what we would prescribe for sleep. They were essentially kind of more the like psychiatric realm and of doses like 200 to 400 milligrams. And sometimes they looked at extended release as well, which isn't classically used for insomnia. So I wanted to look at this open label study, and it looked at quetiapine at more of those doses that we would prescribe for insomnia. They would prescribe about 25 milligrams, 1 to 2 tablets every 4 hours as needed for opioid withdrawal. And they did find that there were some benefits in terms of reducing some opioid withdrawal symptoms. And namely, they also, about 1/5 of participants noted that it alleviated insomnia symptoms. In terms of other populations, there was a human lab study that looked at quetiapine in cannabis use. It was essentially a very prelim study to see if there was anything to study, and they essentially concluded that quetiapine would not be a promising agent for cannabis dependence. Even though it improved sleep, they did find that there were increased cravings for marijuana and increased marijuana use in the population they studied, which was not treatment seeking. All right. The last study I wanted to highlight was this retrospective study that was done in Spain at a treatment center. The reason why is because they use dosages that are kind of similar to what we may use in practice, with the median being about 50 milligrams of Seroquel or quetiapine. And they also, it's the only study that looked at participants with multiple substance use, namely heroin, cocaine, and alcohol. And this is kind of more of a more common patient that I would see sort of in Vancouver and the downtown east side. Basically, they found that there were significant improvements of subjective sleep as well as global scores. In their treatment center, they did prescribe benzodiazepines for kind of some of the management as well, and they found that they were able to significantly reduce how much they were prescribing. Of course, it's a retrospective study done in another country with very different practices, so it's challenging to kind of draw significant conclusions from this. But with kind of all the information we have, it seems like there are some benefits for sleep and withdrawal symptom management for alcohol and opioid use disorder. Maybe not so much for marijuana and cannabis use, but because of all the kind of significant side effects that we do know for quetiapine, a lot of kind of caution should be exercised when prescribing this, and a lot of patient education should be done at the same time. All right, we're on number 4, mirtazapine. So mirtazapine is a noradrenergic and specific serotonergic antidepressant. It's also known for its sedating effects and thought to be due to its antihistamine effects. It's studied quite a bit in people with major depressive disorder, which makes sense because it's a recommended treatment for that. And they found that there were significant improvements in sleep efficiency, quality, and total sleep time for those patients. In the general public, there's a little bit less studies, but it seems that it also improves sleep for them. Some highlights for this medication: it's not known to be addictive, toxic in terms of like respiratory depression, or have significant side effects aside from increased appetite and sleep. And in addiction medicine, I feel like more recently I've been seeing mirtazapine being prescribed quite often for sleep disturbance management. And it seems that people are quite excited about it. There was this group in Texas, USA, that actually argued that mirtazapine could be considered a potential kind of one-stop, all-encompassing strategy for treatment of opioid withdrawal symptoms, because they argue that can help with nausea, vomiting, insomnia, anxiety, diarrhea, and possibly even cravings. And they think that that may be the case because of its kind of serotonergic and noradrenergic receptor effect. It can also indirectly increase dopamine levels in the brain in a way to help manage cravings. So what's the evidence we have in the literature? Fortunately, not a lot. We have a couple pilot studies highlighted here in alcohol and opioid use disorder. The one for alcohol found that there were improvements in depressive and sleep disturbance symptoms, and that these improvements did persist on the 2-year follow-up. Of note, it's a small study, it's only 12 participants. And they also noticed that there were improvements in kind of number of drinks per week, and which decreased from about 38 to 17. In opioid use disorder, there was a pilot study looking at 10 individuals on methadone maintenance therapy, and they essentially, each of them had received all 4 of these treatments, just with kind of a week or 2 in between to kind of wash out. And it was done in kind of a randomized order. So they either received placebo, mirtazapine, a Z drug, or a combination of the 2. And they found only the mirtazapine arm alone improved total sleep time, sleep latency, and sleep efficiency. Mirtazapine also has some data in stimulant use disorder, which we haven't really talked about yet. So in cocaine use disorder, there was a 12-week RCT that looked at mirtazapine in people with cocaine dependence as well as depression. And they found around week 4 that there was some improvement in sleep latency in the mirtazapine arm. Unfortunately, it didn't really impact cocaine consumption, but I guess fortunately it didn't make it worse. In terms of in terms of methamphetamine use disorder, there were mixed results. There was a placebo-controlled trial that looked at mirtazapine in methamphetamine use disorder, and they found that essentially it didn't really improve sleep, and it also didn't reduce methamphetamine use compared to placebo. On the flip side, there was another double-blind RCT that looked at mirtazapine in a very specific group, cisgender men and transgender women who have sex with men, in an outpatient California research clinic setting. And they found that for this group, mirtazapine did significantly improve abstinence and have a net reduction in depressive symptoms as well as insomnia severity compared to placebo. So with all that in mind, there's a lot of potential for mirtazapine, especially in patients who have comorbid depression, but there's just really small studies and there's not a lot to go off of. So further studies with larger cohorts would be much appreciated. All right, so next we have over-the-counter medications. So this is where we talk a little bit about circadian rhythm. It's another part of kind of our neurobiology that regulates sleep. And melatonin is a neurohormone secreted by the brain, particularly at night, that helps regulate this. And circadian rhythm disruptions are known to be associated with substance use disorders. So it's postulated that maybe if we can help correct that, potentially we could help with their sleep management. Another medication to note is tryptophan. It's an amino acid that gets kind of broken down to serotonin and melatonin. So I think of it kind of as a precursor for melatonin. Of note, the American Academy of Sleep Medicine does not recommend melatonin or tryptophan for the treatment of sleep. And it's a weak recommendation based on the fact that there's just really limited data available for these medications. But what we do know is that there is generally low misuse potential, and there's minimal known side effects. So in substance use, we have a systematic review that actually looked at melatonin. They included 12 RCTs. Most of them were about benzo use disorder, and then there was one each for alcohol and opioid. So in the benzo use disorder, they found that there was pretty mixed results in terms of the improvement of sleep quality. And they also noted that there was no benefit in terms of benzo discontinuation rate in people who were kind of on a long-term benzo taper. For opioid use disorder, there was only one study. It showed that there was some improvement in sleep quality, but again, it's just one. And for alcohol use disorder, they found no sleep quality improvement. But they did acknowledge that there were two studies that they couldn't include in the review that looked at melatonin agonist treatments, which I don't think are available in Canada, but they did improve sleep quality. So perhaps maybe we are just limited by how little data we have available. The other thing I noticed was that none of these articles looked at objective findings with polysomnography. And there were no other RCTs for other substance use disorders that were included. There was one for nicotine withdrawal, but they did not talk about sleep. In terms of tryptophan, we have even less. We have 3 articles that I found. One was on cocaine dependence, and this RCT essentially found that tryptophan did not significantly improve subjective sleep quality, and there was no impact on cocaine cravings or use either. The other article comes from China. It looked at something called Magu, which I was like, I don't know what this is. When I looked it up, they said it was a combination of like methamphetamine with caffeine. So I'm going to interpret this as kind of the methamphetamine in China. It was a randomized controlled trial as well, and they actually found that there were some significant improvements in the kind of subjective sleep scores that they had kept compared to placebo. And the last article was a really, really old study from like 1975 that looked at objective REM fragmentation in people with alcohol dependence that were just recently detoxed. And they found the word for word they wrote 5-hydroxytryptophan decreased REM fragmentation in majority of patients. with like no other information about how many patients that was. So all to say, there's not a whole lot of literature that's available to support for or against these medications, but there are fairly minimal risks that are known associated with these medications, and it's pretty widely available since it's over the counter. Could be a potential option for sleep, but more studies would be nice. The last group I want to talk about is dual orexin receptor antagonists, otherwise known as DORAs. So these are medications such as lemborexant, and it's a medication that's actually approved by the American Academy of Sleep Medicine. Uh, and the mechanism of action is essentially by inhibiting the effect of orexin by binding to the orexin receptors. It will help reduce wakefulness. Of note, it is considered FDA Schedule 4 medication, which is the same category as benzodiazepines and Z drugs, but it's thought to have a low misuse and addictive potential based off of some data from internet surveillance and FDA adverse event reporting systems. And there's been a lot of hubbub in terms of these medications in addiction medicine. They found that orexin may be part of something called motivational plasticity, which is kind of this coordinated brain response to rewarding stimuli. And they argue that maybe orexin dysregulation could potentially contribute to addiction, where we have super, super high levels of orexin may result in kind of this like hypermotivation or kind of strong desire for a particular drug. And this excitement is seen in the literature. There's a lot of articles being like, when are we going to use this? And there's a lot of clinical trials that are available as well. Several have been completed, but none of the studies from these articles have come out yet. Sorry, none of the study results have been published yet. So I look forward to hearing about these. But out of the articles we do have, I have two to share. We have this article that essentially is a prelim exam looking at randomizing non-treatment seeking individuals with cocaine use disorder to receive either suvorexant or placebo. And out of the 20 individuals, they found essentially that there was some improvement for restful sleep and sleep-wake switching. But some other factors weren't improved, such as the overall kind of global sleep index score, as well as the total sleep. So maybe there's some improvement in sleep quality. And there's another one that looked at specifically opioid withdrawal with suvorexant. It was a randomized control trial that I found the methods quite interesting and quite different than our practice. So I want to kind of talk a little bit about it. Looked at 40 individuals and they looked at kind of both subjective and objective sleep outcomes. In terms of the methods, what they did was it was sort of at this treatment center where they started people on buprenorphine. And after randomizing them on placebo versus suvorexant 20 milligrams versus double that dose, they essentially had these participants undergo a buprenorphine taper for a pretty short period to induce opioid withdrawal. And they had some adjunct symptomatic management treatment as well for the withdrawal management. But as you can see, a lot of participants ended up dropping out as well because of this. And after they follow up post taper too. And in terms of their outcomes, they found that in terms of sleep, they noticed quite a bit of improvement in terms of sleep duration for suvorexant, as well as increased total REM sleep. And then some improvements in terms of reducing REM onset latency in the post-taper period. For opioid use disorder outcomes, they found that there was improvement in terms of withdrawal symptoms and subjective withdrawal symptoms, as well as one of the questions they had that they found was significant was the suvorexant group cited that there was an increased desire to avoid opioids. The challenge for this article is that I think with some of the practice differences, where in Canada we basically don't recommend opioid withdrawal management, it can be quite challenging to kind of apply this to our practice. I look forward to a lot of the other articles that are coming in. All right, so we're gonna jump into part 3, where we try to figure out how to apply this to our practice. So this is kind of a little approach that I recommended to insomnia treatment in substance use disorder. It's kind of adapted from several papers that I looked at that had a few approaches that they recommended. So the first kind of category is screening for insomnia. Um, Given the high prevalence of insomnia in substance use disorders, and now that we know the impacts it can have on substance use outcomes, I think it's pretty important to screen regularly for it and to manage it. Some ways to do it would be taking a detailed history. You could use one of these kind of sleep indexy scores, things like that. And then I also highlighted stopping just as a reminder to rule out kind of non-primary insomnia reasons why people may have poor sleep. So things like chronic pain, obstructive sleep apnea, mental health conditions, and things like that, because they would often require other management. Part 2 would be kind of some education regarding the link to of sleep and substance use. I always think education is power, and it's important for our patients to know kind of potentially some of the impacts their current use could be having on their sleep disturbance symptoms. And this education can be kind of done during like brief interventions that you may be having with your patients, or during motivational interviewing sessions, things like that. And who knows, this could be kind of a potential driving force or motivating force for them to kind of enact whatever sort of change that they want to make. The other thing is sleep disturbances can kind of vary but be present throughout intoxication, withdrawal, and abstinence. So kind of communicating that and letting them understand what to expect can be quite helpful. The third link is non-pharm management. And this is generally recommended as kind of first-line therapy for everyone, including people with primary insomnia without substance use disorders. So this includes sleep hygiene education, psychotherapy such as cognitive behavioral therapy for insomnia. Keeping a sleep diary could potentially be beneficial for those to understand kind of their sleep patterns and kind of understand what are potential triggers for making their sleep worse. And the other thing I wanted to mention is social factors as well. A lot of the patients that we see may have kind of social circumstances where it makes perfect sense why they have horrible sleep. This could be because they don't have stable housing. They may be sleeping outside and it's very incredibly noisy, and the weather, the rain, everything is impacting their sleep. Or they may be feeling unsafe and they're sleeping with one eye open, and it's pretty hard to have restful, sound sleep if that's the case. So addressing those factors are equally important kind of when doing the management of this. And having a strong kind of interdisciplinary team may be necessary as well. And the last part is kind of the farm management, which we'll talk a little bit more kind of in the next couple slides. And just a reminder to kind of make sure to treat the comorbidities that could be contributing to non-primary insomnia reasons for poor sleep. And the last thing I want to mention about this little diagram that I found or made, you'll see that kind of it's sort of like a chain and things are linked, and that's kind of to just highlight that this approach isn't necessarily linear, and you can kind of do like one part first and then the other, or all together. You may be recommending both medication plus CBTI, things like that. There's no kind of big like right or wrong. These are some resources I want to just highlight for kind of the non-pharm insomnia management. Some nice ones that I like are there's a couple kind of free CBTI options are available as an app and website version. And there's also, I find mysleepwell.ca has some really good information, general information and resources regarding insomnia and CBTI and sleeping pills and things like that, and some books. Also, when I looked on our BC's Pathways referral program, I saw that there were a couple of kind of virtual based group CBTI sessions that are available through referral. So that may be something that you guys want to check out for your patients. Okay, so kind of going back to the farm stuff. Um, uh, One is trying to figure out an approach to selecting kind of the right medication for our patient. I think the first is actually going to help for sleep. Um, for any treatment, we always try to make sure that's helpful. And if it's supported by the literature, that's great. Obviously, we know that that's not always available for us, especially in our population. So the next kind of recommendation uh, that this group recommended was essentially to look for anything that would help for substance use outcomes as well. So additional relapse prevention benefits. And it's really kind of as a means to kind of kill two birds with one stone. If we don't have anything that includes things like that, then we look at the next step, which is, okay, what are some of our insomnia guideline approved medications that have low potential for misuse? So often that would exclude things like benzodiazepines and Z drugs. So it could suggest things like doxepin or even our DORAs as well. And then the last part would be to think about, are there any comorbidities that we can kind of treat as well? So we mentioned how mirtazapine has some good evidence in for depression, and then also for particularly the groups with substance use disorders plus depression. So this could be potentially a good avenue to address as well. Things like neuropathic pain, potentially gabapentin could be an option. Some other things to think about would be, are they current in terms of interactions with substances or medications? They've had things that have been helpful in the past. The side effect tolerance, kind of things like quetiapine, like what we talked about. And really, all this is kind of just suggestions as to how to kind of think it through. But I think there's no hard and fast rules where for these medications, because we don't have so much evidence, we're always going to kind of have to think it through and talk it out with our patients. So it is a little bit more effort on our end. This is a little table that kind of just summarizes what we talked about. The main thing being that for trazodone, there were some benefits, but there were concerns for worsening alcohol use disorder outcomes, but potentially could be mitigated with co-prescribing and chronic relapse prevention medication. Not much for opioid use disorder. For gabapentin, lots of mixed evidence in alcohol use disorder, potentially some reduced insomnia and a combination, fairly safe in alcohol use disorder, not so much in opioid use disorder. Quetiapine, potentially beneficial, but those side effects that we talked about. Mirtazapine, also potentially beneficial, especially with comorbid depression. Some mixed results for methamphetamine. Over-the-counter, melatonin, tryptophan, potential sleep improvements, but just not that much literature available. And potential for DORAs in cocaine use disorder and maybe opioid use disorder, but we should probably wait for some of the upcoming trials, especially I think I always get a little hesitant when I hear about new sleep medications that are branded for low misuse potential. Uh, Historically, I'm sure a lot of people feel that way too. So I may be a little bit more hesitant with these new medications, especially because it's not covered by our provincial formulary. All right, so I don't know if that table felt a little dissatisfying to you, but it kind of does for me, mainly because the literature is quite limited in terms of what's available, right? There are small pilot studies for the most part, short treatment durations, the scaling and how they're looking at sleep is quite heterogeneous. It's hard to generalize. So with that in mind, the approach for insomnia, we should make sure we're screening and treating for comorbid insomnia. But really, we should make sure we're doing a lot of patient education in terms of kind of the non-harm insomnia treatments as well, and that should be addressed. In terms of prescribing medications, which we often will still do, there's a lot of balance that needs to be made in terms of the harms and benefits and making sure that patients know what they're getting themselves into and to have good kind of informed consent. Yeah, and that's pretty much it for my presentation. Thank you, everyone. Oh, and there's a survey.
Awesome. Okay, thank you, Grace. That I don't think you need to apologize. I think that was a very helpful summary at the end, really practical. Obviously, lots of gaps. But that was really a helpful framework for me. I'm just about to get a call from the ward. So, but any questions from the audience or online?
There's one in the chat. How do I get to said chat?
So I'll just read it out line. So Emma Garrett's asking online, anything focused on the early recovery period specifically? So those immediate weeks following withdrawal management.
Yeah, thanks for the question, Emma. So there were some articles that looked at that. Very limited. A lot of them were had participants who were essentially detox or not using substances for at least like 3 to 4 weeks is what I was seeing. So I initially was trying to kind of focus on more the early recovery period, but I found that there was just not enough literature to do that.
Any other questions from the audience?
There is.
Just keep it
Oh,
as well.
sweet. And Emma's wondering our thoughts on addiction specialists managing insomnia given their interplay with substance use. Sometimes these complaints get directed towards primary care. I think that's a really good question. I mean, it's hard for me because of my background's in family meds, so I feel like I just like to manage everything if I can. I think be I think it's tricky. I think it would depend on the practitioner as well as kind of the comforts of the primary care provider as well. I think having a good relationship with kind of between the two providers would be important to at least have some discussion. And maybe if you're noticing something that providers are giving and then you're hearing feedback from patients that perhaps it's there's more harms for the medication and that maybe another one should be considered, you could kind of communicate that with the provider. But I think, oh, okay, like if someone didn't have a PC provider, I think it would be very dependent on the comfort level of the addiction provider. I think I think I would lean towards prescribing or managing it if it's especially because it can be so deeply related to substance use as well. That's kind of where I'm leaning towards. Alicia?
Briefly mentioned at the beginning, doxepine was an option that's recommended for sleep, and I was wondering if you came across any evidence for CAs like amitriptyline or nortriptyline that we might reach for sometimes for pain, which is a common comorbidity for against.
Yeah, so Felicia's question was that I mentioned doxepine, one of the tricyclic antidepressants, and there was any literature that was seen for other tricyclic antidepressants, such as amitriptyline that may be used for like chronic pain and such. There was a couple that kind of compared sort of gabapentin or trazodone with one of the other like tricyclic antidepressants. I cannot recall the effects of it, but I will say there wasn't a whole lot of data that I was seeing. And I will say I don't really see it prescribed a whole lot for sleep alone. But definitely I have seen it for kind of with comorbid like chronic pain and stuff. Okay, I think I saw Mark's hand, then Karen.
Grace, that was a really interesting review. Thank you very much. I'm interested in the effect of caffeine. Did you see anything in the studies that you reviewed as to whether or not they controlled for caffeine? It always strikes me as very interesting that there are probably many detoxes that have coffee machines available. And I've observationally, I think that, you know, a lot of people that use substances, they turn to sugar, and coffees often has sugar included. People who have an alcohol use disorder are often focused on having a beverage, and they sometimes in a detox, they switch from alcohol to coffee. Would you consider that part of the non-pharmacological management that you mentioned in your scheme? Or how should that be addressed? I also wonder whether the caffeine should be tapered in a detox, or should it be stopped suddenly?
Okay. Great question from Mark. He was asking essentially if any of the studies kind of accounted for caffeine, and in particular, he mentioned experiences in detox where patients may often replace their previous substance with kind of caffeine that's readily available, or coffee in the detoxes. I've certainly seen that as well. I think my first experience when I was in Ottawa at our assessment stabilization unit, there was a lot of coffee readily available, and they were drinking a lot more cups than I expected while kind of going through detox. In terms of the studies, for the most part, they would exclude all substance use disorders except nicotine, and they did not mention caffeine. So my understanding is they probably did not account for that at all. In terms of, I mean, we certainly do know the effects of caffeine can have on sleep, and it's generally recommended kind of in the sleep hygiene education in terms of reducing caffeine levels for sleep as well. I think in terms of approach to how to, if a patient was interested in kind of improving their sleep and reducing their caffeine intake, the approach of whether stopping cold turkey compared to tapering would probably be dependent on the patient. Although I think tapering would require the patient to be quite kind of structured themselves. I don't know if we have a way to kind of help monitor and like taper it for them, if that makes sense. So I think it would be a big discussion with them. But I would think of it more as kind of in the non-pharm realm, in the sense that we're not giving them something to treat for sleep, but rather we're kind of counseling around sleep. Any other questions? Karen, do you still have a question? Okay, no worries.
Now that a lot of detox centers are not serving coffee that is non-caffeinated now.
Ooh,
Well, we put a lot of.
Oh. Good to know. Yeah.
I think my question was something to do with anitriptyline as a sleep pad.
Mhm.
Notice if there's anything in.
Yeah. Yeah. So the question was amitriptyline and why it wasn't included. I think I just haven't really seen it prescribed too much for just sleep alone. So it wasn't included. I will say I didn't do a big overview look at that medication in particular. But there were a couple studies I saw that were kind of comparing amitriptyline or one of the other triptylines to something else.
So plus anitriptyline. And then I got told that was not very safe to do that, so I think we're only got to cut that part out.
Okay. I'm not sure about kind of the combination of trazodone and amitriptyline and the safety regarding that. I don't think I know a lot of safety concerns off the top of my head of that combination, but probably they were hoping to kind of consolidate to one medication to kind of maybe help manage your sleep that way. But of course, I wasn't part of your care, so it'd be hard for me to comment too much on that. I think I see a question in the chat. Yeah, question is if I came across any literature around sleep disorders like narcolepsy and excessive daytime sleepiness, the risk of substance use. for those kind of misdiagnosed essentially, since we rarely do testing for those. Great question. I focus my look primarily into more like primary insomnia and kind of sleep symptoms around substance use disorders. So I didn't specifically look for those disorders, and my understanding is most of the articles that did exclude these types of kind of other sleep disorders. But I think you do bring up a really good point where these kind of other sleep disorders are important to screen and look for. And if there are signs where it doesn't seem entirely like primary insomnia or kind of substance induced, then I think referral to like a sleep clinic would be pretty important. Okay, I think that's it.
Thanks so
Thanks
much.
everyone.